right now as you're listening to this, I want you to just press your tongue against the roof of your mouth.
Just feel how much space it takes up in there.
Yeah, exactly. Notice how easily it moves, how it naturally seals right up against your teeth.
It's something you do all day without even thinking about it.
Right. Now, I want you to imagine a surgeon sitting across from you, telling you they have to remove half of it.
Have your tongue.
And while they're telling you this, they're simultaneously guaranteeing that you'll still be able to swallow your lunch and speak clearly the very next day.
Which just sounds completely impossible.
It really does. How is that mechanically possible? Well, that is our mission for today's deep dive. We are exploring this unbelievable, just incredibly high stakes balancing act of head and neck surgery.
Right, and specifically, we're looking at some fascinating excerpts from the Open Access Atlas of Otolaryngology, Head and Neck Operative Surgery.
Which is quite a title.
It is a mouthful, yeah. But we're focusing on a chapter by Johann Fagan. It's all about partial glossectomy, which is just the surgical term for removing part of the tongue.
And reading this text, it really exposes a surgical landscape where just eradicating the cancer is, well, it's only half the battle.
Barely half, honestly. The other half is preserving the patient's fundamental ability to just interact with the world.
And the stakes of getting that balance wrong, I mean, they are incredibly grim.
Very grim.
There's this visual mentioned right near the beginning of the text, and it really sets the tone for the entire procedure. It's this historical reference to something called the Andy Gump deformity.
Yeah, so Andy Gump, for those who don't know, he was this really popular cartoon character from the early 20th century, and he was drawn entirely without a lower jaw or chin.
Just a totally flat profile from the nose down.
Exactly. His face just sloped in this straight, uninterrupted line right down to his neck. And in the surgical world, when they use that term, it describes a catastrophic complication.
Like a literal worst case scenario.
Right, because if a surgeon removes the front arch of the lower jaw, the mandible, and they detach the neck muscles, but they don't properly reconstruct that bony arch.
Which is basically the anchor for everything.
It is. If that anchor is gone, the remaining neck muscles just constantly pull downward.
So the entire lower face just basically collapses inward and downward.
It does. It totally caves in. And, beyond the obvious cosmetic devastation of that, the text really emphasizes the complete loss of oral competence.
Oral competence, meaning just the ability to use your mouth for basic things.
Exactly. Without that bony framework acting as like a retaining wall, the patient literally cannot keep saliva or food inside their mouth.
Oh, wow.
Yeah, they suffer from severe drooling, profound speech impairment, and an inability to safely swallow. It's basically a total failure of the oral machinery.
So to avoid disastrous outcomes like that, we first really have to understand the machinery that these surgeons are navigating, right? Because I think most of us probably think of the tongue as just, one big solid lump of muscle, just a hunk of meat. But reading this, I realized it is an incredibly complex biomechanical system.
It's totally modular. People don't realize the tongue is actually comprised of 8 distinct muscles.
8
of them. And they operate in 2 specialized teams. So 4 of these are what we call extrinsic muscles.
Okay, extrinsic meaning outside.
Right, they're physically anchored to the jawbone or to the hyoid bone way down the neck, and their primary job is macroscopic movement.
Like the heavy lifting.
Exactly. Pulling the whole tongue backwards, sticking it out, sweeping it from side to side.
Okay, so that's the first team.
Yeah.
Then you have the fine-tuning team, right? The 4 intrinsic muscles.
Yeah, and those 4 are super fascinating because they don't actually attach to any bone at all.
Wait, really?
Not a single bone. They exist entirely within the tongue's own structure, just floating in there essentially.
So what do they push against?
They push against each other. Their sole purpose is just to alter the tongue's physical shape in 3 dimensions. So they're the ones that allow the tongue to flatten out or narrow or, curl its edges into a bowl shape.
Or like pointing the tip when you're trying to reach your teeth.
Exactly.
So the extrinsic muscles act like the heavy lifters moving the whole unit around the mouth, and then the intrinsic muscles are the precision tuners, letting you, articulate words or roll your R's.
Yes, perfect way to put it.
But then beneath that highly dynamic structure, there lies this foundation. The text highlights this muscle called the mylohyoid, and it basically forms the floor of the mouth.
Right, the floor.
And looking at the diagrams in the atlas, it literally looks like a fleshy trampoline, just stretching from one side of the jaw to the other.
A fleshy trampoline is a great analogy.
It completely separates the wet inside of the mouth from the neck below it, and it just supports that entire tongue structure above it.
And when a surgeon is operating right on top of that trampoline, they are navigating this remarkably dense network of plumbing and wiring. It is packed in there.
Just a minefield.
It is. So the primary blood supply, for instance, comes from these paired lingual arteries running deep underneath the tongue.
Yeah.
And as they travel toward the tip, they transition into the Ranine arteries. And those are accompanied by these thin-walled veins that actually you can see if you lift your tongue in a mirror.
Oh yeah, the bluish ones right underneath.
Yeah, those exactly. But what is truly wild to me is the wiring, the nerve distribution. It relies on this bizarrely decentralized division of labor.
Yeah, this part blew my mind. Because if you think of like a typical muscle in your arm, one major nerve cable usually handles everything, right? It tells it to move, and it tells your brain it's being touched.
Right, and all in one package.
But here, the functions are completely split up.
Totally split. The movement of those 8 muscles we just talked about, that's driven by a single motor wire, the hypoglossal nerve.
Okay, so that's the gas pedal.
Exactly. But sensation is entirely outsourced. The front 2/3 of the tongue relies on one nerve for basic touch and temperature.
Right.
But the perception of taste for that exact same area is piggybacked onto a completely separate 3rd nerve cable.
Just for taste.
Just for taste. And then if you move to the back 1/3 of the tongue, yet another distinct nerve takes over both touch and taste for that zone.
So for a surgeon, that division of labor means you could flawlessly preserve the motor wire, saving the patient's ability to chew and swallow, but you could accidentally nick the taste wire.
Yes.
So they would have a perfectly functioning tongue, it moves perfectly, but they might just never taste the food again.
Which is devastating. So it requires just this microscopic situational awareness.
Yeah.
And on top of that, the physical texture of the terrain itself is constantly fighting the surgeon.
How so?
Well, the underside of the tongue is lined with this thin, smooth, pliable tissue, right? And the front top surface is also relatively uniform.
Like what you feel when you rub against your teeth.
Exactly. But as the surgeon moves backward toward the base of the tongue, the part that's disappearing down your throat, the landscape radically transforms.
Right, the text gets really descriptive here.
It does. The tissue back there becomes thick, rough, and deeply tethered to the muscle underneath it. It's just packed with these bumpy lymphoid follicles.
Which sounds like a total nightmare for detecting cancer.
Yeah.
If you were hunting for a rough, bumpy tumor, and the surrounding healthy tissue is naturally rough and bumpy,
The cancer is essentially wearing perfect camouflage.
that is terrifying.
It is. And the text specifically warns that determining the actual perimeter of a base of tongue tumor just by sight or touch is nearly impossible. A surgeon cannot simply look at it and know where to cut.
So what do they do? Just guess?
No, they rely on this intraoperative technique called frozen sections.
Okay.
So the surgeon makes an initial cut, removes a sliver of tissue from the edge of the wound, and hands it directly to a pathologist right there in the operating room.
While the patient's still open on the table.
Exactly. The pathologist rapid freezes the tissue, slices it micrometers thin, and checks it under a microscope for cancer cells immediately.
Wow. So they just have to keep blindly expanding the crater, freezing it, checking it, and cutting again until the pathologist finally gives them the all clear.
Yep, margin by margin.
Because it's so camouflaged, you really can't just open the mouth and wing it. You have to map the exact borders and risks before you ever pick up a scalpel.
Absolutely.
Which takes us right into the preoperative planning phase. And there is a phenomenon mentioned here that completely changes the entire scope of the surgery. It's called perineural invasion.
Right, perineural invasion, or PNI. This is a truly devastating mechanism where the cancer discovers those very nerve highways we just discussed.
The sensory and motor cables.
Yes. Tumor cells actually infiltrate the protective sheath surrounding a major nerve, and they use that path of least resistance to travel far beyond the original mass.
They're literally riding the body's own wiring deeper into the head.
It's sinister. If a patient presents with a tongue tumor, but they also complain of, say, sudden numbness in their lip, or the surgeon notices the tongue kind of deviating to one side,
Then the cancer's in the wire.
exactly. It strongly suggests the cancer has hijacked a sensory or motor nerve. And in that scenario, just removing the primary tumor is completely inadequate.
Because it's already left the station.
Right. The surgeon must physically trace that infected nerve backward, literally dissecting it toward the brainstem.
Oh my God.
And they have to repeatedly send cross-sections to the pathologist until they finally find a segment of the nerve cable that is completely free of cancer cells.
So they're just chasing the cancer down the wire.
Yep.
And while they're tracking these microscopic pathways, they also have to evaluate the big picture, right? The macrostructure, specifically the jawbone.
The mandible. Yeah.
And I noticed the author gives a very specific warning about dentalist patients, which just means older patients who have lost all their teeth. At first, I honestly couldn't figure out why an empty gum line matters if the target of the surgery is the tongue.
It's a great question, and it comes down to bone biology. The jawbone really exists largely to support the roots of our teeth.
Okay.
When those teeth are lost or extracted, the bone no longer experiences that daily mechanical stress of chewing.
Like use it or lose it.
Exactly that. Without that stress, the body just stops maintaining the bone. It slowly resorbs. The jaw literally shrinks, losing massive amounts of its vertical height.
Wow. So a toothless jaw isn't just an aesthetic issue. The actual skeleton of the face atrophies.
Yes, and that structural atrophy creates a hidden trap for the surgeon. See, there is a major nerve running longitudinally inside the jawbone, which eventually exits to provide all the feeling to your lower lip and chin.
Could it?
In a young, healthy jaw with deep tooth roots, that nerve tunnel is buried safely, deep inside thick bone.
But if the jaw shrinks down to half its height over the years.
That nerve suddenly ends up sitting right on the upper surface of the bone, totally exposed.
Oh wow. So a surgeon operating near the floor of the mouth, who expects the nerve to be an inch deep, could easily sever it just by making a standard incision.
In a split second. Furthermore, if the tumor is sitting close to the jaw, the surgeon might need to shave away the inner layer of the bone to ensure all the cancer cells are gone. That's called a marginal mandibulectomy.
Right.
A healthy, thick jaw can afford to lose a layer and still remain structurally sound, but a shrunken, atrophied jaw, it might just snap right under the pressure of the surgical tools.
So that structural reality completely changes the geometry of the entire operation.
Completely.
But, having teeth can actually be a massive problem too. The text outlines this bizarre paradox where a patient facing life-threatening tongue cancer might be forced to go to a dentist to have teeth pulled before the cancer surgeon will even touch them.
Yeah, this is a critical preventative strike against a condition called osteoradionecrosis.
Which sounds awful.
It is. Post-operatively, many of these patients require high-dose radiation to eliminate any microscopic cancer remnants. Now, radiation is highly effective, but it severely damages the tiny microblood vessels within the jawbone itself.
Okay, so it cuts off the blood supply.
Right. The bone becomes an avascular wasteland.
It survives, but barely.
Exactly. It was just hanging on. So if a patient goes into radiation therapy with a cavity in one of their teeth, that cavity is essentially a ticking time bomb.
Because of the bacteria.
Yes. Months later, bacteria from that cavity can travel down the root and infect that irradiated jawbone. And because the blood supply was destroyed by the radiation, the body literally cannot send white blood cells or antibiotics to fight the infection.
So it can't heal.
It can't. The bone literally dies, crumbles, and rots inside a patient's face.
Oh, that is horrific.
It is an incurable condition once it starts. So to prevent it, any tooth with even questionable health must be extracted weeks before the cancer surgery even happens.
Just to allow the empty socket to completely heal over before the radiation begins.
Exactly. You have to seal the vault.
Okay, so the nerves are mapped, the skeleton is measured, the bad teeth are pulled. But there's an even more immediate survival problem that they have to solve during this planning phase. And that is keeping the patient from basically drowning in their own fluids.
The airway risk.
Yes, right. Because if we go back to our fleshy trampoline analogy, that mylohyoid muscle separating the mouth from the neck, what happens when a surgeon has to detach it to reach a tumor?
Well, the entire structural integrity of the airway collapses because the muscles of the mouth floor, they don't just hold the tongue up, they actually send the larynx, the voice box.
They hold it up from above.
Yeah, they pull it forward and keep the windpipe open and protect it. If a surgeon severs those front attachments to access the base of the tongue, gravity and muscle tension from the chest just take over.
So larynx just drops.
It drops backward and downward.
Pulling the airway wide open directly beneath a bleeding surgical site.
Exactly. The patient totally loses their mechanical ability to protect their windpipe. They are at an extreme risk of aspiration.
Meaning inhaling fluids.
Right. Inhaling saliva, blood, or postoperative swelling directly into their lungs, which causes fatal pneumonia.
So how do they bypass that?
The text is unambiguous here. To bypass this deadly risk, the surgeon performs a tracheostomy.
Right.
They cut a temporary hole directly into the front of the neck, below the vocal cords, and insert a breathing tube. So the patient breathes entirely through their neck while the mouth and throat undergo all this demolition and healing.
Wow. Okay, so the airway is secured down below. But now we have a purely mechanical problem. Physically getting heavy cutting tools into the tight, dark space of the mouth without destroying the patient's face.
Right.
I mean, for a small tumor on the tip of the tongue, the text says they just prop the mouth open. But for larger tumors at the back, working through the front door is just impossible.
It's way too tight. They require radical access. They literally have to split the soft tissue of the face and the rigid structure of the jawbone wide open.
So this involves what they call a mandibulotomy with a midline lip split. And I was reading the steps for the lip split. And there's this brilliant, subtle technique they use before they even pick up the scalpel. They score the vermilion border.
Oh yeah, this is crucial.
Yeah, so the vermilion border is the exact line where the pink of your lip meets the regular skin of your face. And before cutting vertically down the lip and chin, they take a needle and make these tiny scratch marks horizontally across that border.
Right.
And I instantly pictured, drawing a pencil line across two pieces of patterned wallpaper before slicing them.
That's exactly why they do it. It guarantees perfect realignment during the reconstruction phase.
Because our eyes are so good at spotting mistakes there.
Incredibly sensitive. The human eye picks up on facial asymmetry instantly. If the surgeon sews the lip back together and the vermilion border is misaligned by even a single millimeter,
It's glaring.
yeah, it creates a visible, permanent step-off deformity. So those tiny pre-surgical scratch marks act as an infallible map for the final stitches.
So they slice the lip, they peel the soft tissue of the chin completely back, exposing the jawbone. And then they have to cut the bone in half.
And the tools here sound terrifying.
They really do. They use power saws, or something called a giggly saw.
Right. A giggly saw is a length of flexible wire coated in sharp cutting teeth, and it has a handle at each end.
Like a wire garrote almost.
Basically, the surgeon threads the wire completely behind the jawbone, grabs the handles, and vigorously pulls back and forth using friction to saw through the bone from the inside out.
And the crazy thing is, they don't just make a straight vertical cut down through the bone.
No, a straight vertical cut would be structurally terrible. You have to remember, the human jaw generates massive shear forces during chewing.
Right.
If you just bolt a straight cut back together, those shear forces will cause the two halves to slide vertically against each other. It'll ruin the patient's bite alignment and prevent the bone from ever knitting back together properly.
So what's the shape?
The surgeon maneuvers the saw to create a V shape or step notch. This creates interlocking geometric pieces.
Oh, like a puzzle.
Exactly. So when the jaw is bolted back together with titanium plates at the end of the surgery, that V-cut physically locks the bone in place against the downward pressure of chewing.
That is so smart. But to make that cut without destroying the healthy teeth sitting right next to the saw blade,
Yeah.
they have to perform this calculated sacrifice.
Yeah, they do.
They actually extract a perfectly healthy tooth right in the middle of the cut line and then saw directly down through the empty hole.
They have to. The friction and heat generated by bone saw are just intense. If a surgeon tries to cut through the narrow gap between two teeth, the thermal trauma will inevitably boil the microscopic blood vessels supplying the roots of those adjacent teeth.
So it would kill them anyway.
It would devitalize them completely. So by sacrificing one tooth and driving the saw through the cavernous space of its empty socket, the thermal energy dissipates. It leaves the teeth on either side of the cut alive and perfectly healthy.
Wow. Now, splitting the face down the middle is just one approach. The text also details alternative access routes that honestly sound like mechanical engineering, like the pull-through method.
Oh, the pull-through is wild.
Yeah. If the tumor is in the floor of the mouth, but it hasn't actually invaded the jawbone, the surgeon doesn't even bother cutting the face. They make an incision low down in the neck, detach the floor of the mouth from underneath the jaw, and literally pull the entire tongue structure down into the neck hole.
They just deliver the target organ right out of its tight anatomical cavern.
It's basically like dropping the engine out the bottom of a car so you can work on it in the open.
That's a great way to visualize it. By dropping the tongue down into the neck, the surgeon gains a 360-degree wide open view of the tumor. They can cleanly carve out the cancer, ensure all their margins are safe, and then simply push the reconstructed tongue back up into the mouth and reattach it to the jawbone from below.
Okay, so once they have that access, whether they split the jaw or drop the engine, they finally arrive at the critical moment of resection.
The main event.
Right. The tumor is exposed, the cautery tools come out, and the surgeon has to carve out the cancer with at least a 1 centimeter margin of healthy tissue on all sides to guarantee no microscopic cells are left behind.
And during this incredibly aggressive excavation, they are hunting for one specific structure that they absolutely must save.
The lingual artery.
Right. We noted earlier that the tongue has a paired blood supply. Now, a surgeon can tie off and sacrifice one lingual artery if the tumor's location demands it. The tongue can survive on a single dominant vessel.
But if they mess up the other one,
If the resection accidentally severs or damages both lingual arteries, the text uses a very specific word: infarction.
meaning total tissue death.
Exactly. The entire remaining half of the tongue suffers infarction. Without blood flow, the tissue simply necrotizes and rots right there in the oral cavity.
Wow.
So preserving that single pulsing artery while you're digging out cancer just millimeters away, it is non-negotiable.
So assuming they succeed, the margins are clear, the artery is pulsing. The patient is now left with a massive crater in their mouth. And now begins the reconstruction. And reading this, I realized I had a massive misconception about reconstructive surgery.
How so?
Well, I assumed the goal was basically just biological carpentry. Like if there's a big hole leaking into the neck, you just find a thick piece of muscle from somewhere else, plug the gap tightly, and stitch it down so it doesn't leak.
A lot of people think that, but that approach fundamentally ignores the biomechanics of the organ.
Right.
Simply filling the void is a functional disaster. The text is definitive on this principle: function over form. It explicitly states that when reconstructing a tongue, length is more important than width, and above all else, mobility is key.
Because if you take a thick, tight patch of muscle and use it to just plug the hole, you end up tethering whatever is left of the patient's natural tongue to the floor of their mouth.
It acts exactly like an anchor.
Right.
If the remaining native tongue cannot lift up to touch the roof of the mouth, the patient literally cannot articulate consonants to speak.
And swallowing is even worse.
Much worse. They lose what's called oral transport. The text illustrates this vividly. If a surgeon uses a flap that is too broad, it forms this deep trough in the mouth.
Like a ditch.
Yeah, a ditch where saliva and food naturally pool. But because the tongue is tethered by that bulky flap, it cannot perform the sweeping motion required to push that pooling liquid backward into the throat.
So they just constantly drool.
They constantly drool, totally unable to swallow even their own natural secretions.
So the replacement tissue has to move and flex exactly like the tissue that was removed.
It has to mimic it perfectly.
And the author provides this sort of menu of flaps, which is tissue borrowed from elsewhere on the patient's body, and evaluates them entirely on their biomechanical properties.
Right, and the top tier option on that menu is the radial-free forearm flap.
Which means taking skin from the arm.
Yes, the surgeon harvests a patch of skin, fat, and fascia right from the patient's inner forearm, completely detaching it along with its native artery and vein. Forearm skin is uniquely thin, highly pliable, and it folds really easily upon itself. When it is transplanted into the mouth, it accurately mimics the thin, supple nature of native tongue tissue.
But how does it survive if it's completely detached?
That's the amazing part. The surgeon performs microvascular anastomosis. They use a microscope to meticulously sew the tiny blood vessels from that forearm tissue directly into the pulsing arteries and veins of the patient's neck.
They literally plummet into the neck.
Yep, completely restoring blood flow to the transplanted patch.
That is wild. Now, another highly rated option is the Buccinator myomucosal flap, which uses tissue harvested from the inside of the patient's own cheek.
Right, the Buccinator flap is biomechanically perfect for smaller defects because it's already lined with natural oral mucosa.
So it belongs in the mouth.
Exactly. It naturally secretes moisture, it has the exact right thickness, and it stretches seamlessly to replace the floor of the mouth without tethering the tongue.
And then, you have the bottom of the menu, the pectoralis major flap, where they pivot a massive chunk of chest muscle up into the neck and mouth.
Yeah, the text categorizes the pectoralis flap strictly as a last resort.
Because it's just too big.
Basically, yeah. It provides massive bulk. Now, that's useful if the surgeon needs to fill a cavernous hole where the entire jaw and tongue were removed.
Sure.
But for partial tongue reconstruction, its thickness is a huge liability. It is heavy, it's rigid, and it completely lacks pliability. It effectively turns a highly dynamic, articulating instrument into just a static, immobile block of flesh.
Wow. When you really zoom out and absorb the sheer scope of this procedure, it's just this staggering collision of disciplines.
It really is.
I mean, a head and neck surgeon has to be an oncologist, tracing microscopic cancer cells traveling inside nerve sheaths toward the brain.
Right.
But then they also have to act as like a heavy carpenter, sawing through living jawbones and bolting them back together with titanium plates to withstand the shearing forces of chewing.
And microplumbers.
Yes. Sewing millimeter-wide arteries together under a microscope to prevent tissue death. And on top of all that, they're artists, meticulously scoring the vermilion border of a lip so a patient can smile symmetrically for the rest of their life.
The procedure demands an almost impossible psychological duality.
I mean,
Well, the surgeon must be brutally aggressive to ensure the cancer is eradicated, right? But then profoundly delicate and forward-thinking to protect the biomechanics of the human being they're putting back together.
and that tension between aggressive intervention and delicate preservation, that brings us to a final profound paradox in the text.
Okay.
Because I want to leave you, the listener, with this thought. After an entire chapter dedicated to extreme surgical mechanics, splitting faces in half, dropping organs into the neck, borrowing skin from the arm, and sewing its blood vessels to the throat, the author provides guidance on what to do if the surgeon only removes a very small, superficial sliver of the tongue.
Oh, this part is fascinating.
It is, because the clinical recommendation for those small defects is simply no repair.
Literally do nothing.
The text explicitly urges surgeons to resist the temptation to suture. If you cut a small piece out, do not try to neatly pull the edges of the wound together. Do not stitch it up. Leave the crater completely open.
Just open.
Let it bleed, let it form a scab, and let it heal entirely on its own, exactly like a childhood tonsillectomy.
Because every time a surgeon places a stitch in the tongue and pulls tissue together, they alter its natural three-dimensional geometry.
Right.
They risk artificially tethering the muscle fibers, creating internal scar tissue that might restrict that precious millimeter-specific mobility required for speech.
It is a remarkable concept to ponder. I mean, in a highly advanced medical field that is utterly defined by radically altering the human body to save it. Sometimes, the absolute highest level of surgical wisdom is having the restraint to drop the tools, step back, and do absolutely nothing at all, trusting the body's raw, ancient capacity to heal itself.